Hi, guys. Welcome to At the Nurses Station, a podcast for nurses about everything except the patients. Sam and I are here today, and we are talking to one of our favorite people, Levi Bell. He's a nurse practitioner that we have worked with for a couple years now, and I'm super excited to talk to him.
Me too. I really appreciate Levi's, I think just off the jump, Levi's energy. Like when he walks into the unit, stuff gets done, super fun way, and just is like just super enjoyable to work with. So I've always appreciated that about him. And yeah, I'm excited to talk to him about some alternative stuff that maybe people have opinions about. It'd be fun.
Yeah, I can't wait. Let's get him on.
Hi, Levi.
Hey, how are you guys doing?
Good.
Glad to be here.
So if I call Dr. Rochelle, do I need to call you Nurse Practitioner Bell, or is like Levi okay?
I think that would be weird for both of us.
Okay,
since
great.
You've never done that before, so Levi's great.
Has anyone ever done that?
Dear Nurse Practitioner Bell. No. The funniest thing is when our unit staff calls a specialist and they're like, I have doctor, and I'm immediately like, that's not me. I did not do that. But also came from a clinic before coming here when I moved to Spokane that called themselves doctor. Even they got their doctor of nursing practice.
Oh.
So they would refer to themselves as doctor, and I was highly against that because it's just confusing to people who don't understand the difference.
I know that group you're talking about, and it drives me crazy when I ask, so who's your primary care physician? And they're like, Dr. John. Yeah. And I'm like, no.
They're not a doctor.
It's a nurse practitioner so-and-so, but.
Yeah. I chose not to get that degree. I was grandfathered in for my education, but I chose not to get it because it is, my opinion on it is it's a QI project, not a true doctoral degree. If you get your PhD, I will more than gladly call you doctor. But the DNP, in my opinion, is just not on the same level and confusing for patients. So, but anyway, yeah. So yeah, you can call me whatever you want.
A PharmD.
I mean, do you know what's really weird about the pharmacists is they have more education than we do, but they can't prescribe, which is confusing because I would probably trust them to prescribe the right thing for me more often than some of the other colleagues that I've worked with in the past, depending on the pharmacist. But
can we learn a little bit about your nursing background before you became an NP?
Sure. So I started out as an EMT when I was right out of high school. Had no idea what I wanted to do, and my dad worked for a hospital. He's a pilot and ran their remote outreach program, and recommended that I try that out because I had no idea what I wanted to do. And so I got my EMT and really enjoyed it. And so felt like I wanted to do more. And had a colleague who was also an EMT, but went through nursing school afterwards. And I respected his view on just being in that role and being told, having been given instructions and then being the one who was kind of providing those instructions, and just the appreciation that he had for the people that worked under him. I really enjoyed that. And so went to, from there, thought about going to med school, but didn't feel like that was something that I wanted to put that much time into. And with nursing, I was able to get my nursing degree, work, and then knew pretty early on that I wanted to do more and likely go on to be a nurse practitioner. And so I actually started my first class of NP school before I started my first job. But I worked full-time as a pediatric nurse back in Colorado, Children's Hospital, Colorado. I was a pulmonary floor nurse for a stable trach vent floor for a year. And after I had 2 or 3 trach vent kids pass and had some had some qualms with like what we did on that floor, transferred to the ER, which is what I had done. I worked in an adult ER for a summer before I went to nursing school, and knew I wanted to be back there. So then I worked for 2 years as a nurse in the level 1 pediatric ER there in Colorado. And then made a really not fun transition of being a nurse practitioner in the exact same ER, which was interesting. So yeah, that experience was hard fought respect from some old nurses and doctors for that matter. So yeah, so that was interesting. But then I worked there in Colorado. They have a network of care of about 7 different urgent cares and hospitals. I worked in all of them that ranged from like in a 60+ mile radius with 20 different shifts a day between the 7 sites. I worked there for 10 years before moving out here to Spokane.
Oh, wow.
So,
yeah. That's awesome. I didn't know all that background.
Yeah. So
I want to ask about the transition in the same ER.
Yeah.
What made it so hard? Was it your age and your experience?
Yeah, probably a little bit of both. I was 25 when I started as an NP. So I think a lot of people thought I was not experienced or old enough to do what I was doing, which is potentially true. I mean, the whole idea, right, of the nurse practitioner is that you are an experienced nurse before you go into to that role, which I definitely respect. I do see a lot of people completely skipping all clinical practice as an NP, and they go from like nurse to nurse practitioner and don't practice at all as a nurse. And I think those people have a huge learning curve and a lot of struggles. And I've actually seen a few just up and quit because they just have so much struggles with it. I think it does take a different personality of a person to go through that process in a shorter time. I think some people who have been nurses for a long time are amazing at their jobs because they basically have done everything and they've been, nurses for 15, 20 years. That was the original intent behind the nurse practitioner. And I think, I mean, you could potentially say it's a shortcut for people now to not go to med school, but be able to practice as NPs. And again, I'd say on a case-by-case basis, sometimes that works and sometimes it doesn't. But I felt like the experience I gained in the ER definitely prepared me for what I was doing. And the transition was, yes, because I was young, too, because people are just weird with change, I think is a big part of it. And two, I think a big part was that I was fairly new to nursing, relatively speaking, and then also a pretty young provider. And so, it was just a lot of like, I know you think you know more than me, but at the end of the day, like I'm the one going to get sued. So can you just please do what I ask? And when they would do that, and I think it helped that I was well respected as a nurse before I did that. Like if I had been a crappy nurse, I don't think it would have gone very well. And I probably would have quit and moved somewhere else, but was able to transition, I would say pretty successfully. So.
And you have so much of like, what is the ER experience? So that not inpatient, I mean, from being an EMT and then doing so much ER experience, I feel like when we get a provider that is only has inpatient nursing background and then becomes a nurse practitioner and then works in the ER, like it shows.
Yeah.
I'm like, oh, you want me to do things that don't exist here.
Yeah, for sure. Another thing I forgot to mention. So I got bored in the ER after probably 2 years and wanted to keep learning and started looking at acute care in the ICU setting. And so I did I originally got my nurse practitioner with the intent to get my acute care certification. But CU's program, they used to allow you to take any program and then just sit for one or the other test. So the primary care or the acute care test. And while I was halfway through my program, they changed that and you had to go through the correct program to take that test. So I almost quit and transferred. And then it was like, well, I'm almost done. But so I got my primary care, and then the hospital I worked at wanted to have everybody in the ER and ICUs be acute care trained. So I went back and got my postmaster cert. So I have 2 certifications, one for primary and one for acute care. And I did that through Rush University in Chicago. But during that time, I did clinical in the ICU at Children's. I was like, oh, this is really interesting. I really enjoy this. And so after that, I applied for a job, didn't get it, but then they created, and this was probably the worst job I've ever had, because I was a part-time ICU attending and a part-time ER attending. And the way they had it is we worked under a fellow and an attending on basically a step down, or it was all the chronic kids. They were trying to build continuity for that crew, where the residents got all the cool like traumas and all the interesting cases. And so basically in my time there, it ended up, I was basically back on the trach vent floor, but with sicker kids, and essentially a forever super resident is how, because it was always this like, and also I didn't have the background of being a nurse in the ICU. And so like just common stuff like knowing, at the drop of a hat, replacement of all these different things that we just don't do in the ER. I was like, and so after a year, I stuck with it a year, doing 6 shifts a month in the ICU. And then after was like, this is just not for me. And so I went back to the ER full time. So that was like a year stint that I did. But anyway, with that, even the whole, just like really you talked about the ER being a place that like, if you don't know the ER, you struggle there. A couple of them moonlighted in the ER for us one time, and they're just like, I just don't know how you send people home. I'm like, oh man, every day, all day long.
Get used to it.
Yeah. And so, with that too, so many people it's just such a different environment, like that comfort of like, if they get worse, they're going to come back, or like, I can't know everything, and being comfortable with that is much different than the ICU setting of like, counting mLs of urine and tracking bicarb for days, and, all the stuff that goes into the ICU that I am just probably less wired for. So anyway, but that's
I do have a question. When you said you got bored in the ER, I will admit, I've thought about getting my NP in the past, but sometimes when I watch mid-levels practice in the ER, it seems like all you do is see like the level 4s. Here's Tylenol, here's Zofran. You get to stitch things. That's cool.
Yeah.
But do you ever get to the point where you're like, I want to just do more fun
cool
stuff?
Yeah. I think I've even said to both of you, sometimes I miss days of being a trauma nurse, because you actually are involved in those. And I don't know, I try to pop in every once in a while just to kind of see what's going on. But the fact of the matter is, if you're out of practice, like, you're terrible at it. So I'm sometimes not very helpful in there. The interesting thing where I worked back in Colorado, the sites that we worked in, there was they were developing 2 different roles. They were doing like more like an acute mid-level and an urgent care mid-level, if that makes sense. Where when I was leaving, I was encouraging them to even create a pay scale difference, so that like one of the things I saw is we had this like expectation that we see everything, and yet we had this pay scale that paid us for low acuity. And so the amount of risk that you take, in my opinion, should be, comparable to the pay that you receive. And, but also like respecting like the fellowship that our PIM colleagues go through is nothing close to what I do. So how do we meet in the middle, where I'm more interested in helping do what they do, but also don't want to make no money for it? So there's some days it's like, man, like, you don't pay me enough to do that, so I'm just going to sit here and see my, low acuity stuff, and I'm fine with that. And then there's other days where I'm like, oh my gosh, I'm so bored, I would love to do something else. And so in Colorado, the role that I had was actually that kind of higher functioning. So there would be times in our network of care where we would just trade off patients. So whatever came the door, whoever was up next got that patient. And so I was often seeing like, septic treatment kids, or, complex workups. Sometimes my PIM attending had low acuity, like stuff, and it just happened to be. And so it was a little bit more of a collaborative approach. My experience here has been a little bit different, where it's kind of, again, it's totally attending dependent. Like some attendings, like who are more welcoming of, jumping in and being like last night, I had a question about a lac that I was like, I don't know if I need to do anything with this. And the attending was like, oh, can I just go look? I tried showing them a picture, and it was like, can I just go look? And I'm like, oh my gosh, yes, please. Like, half the attendings don't, they'll kind of look, but they don't want to actually go take the time to do that. And so it depends on who you work with. And I would say if there was a role where I could work at a level 1 trauma center and be essentially a super fellow with oversight from an attending, man, I would love that. That would be amazing. That role doesn't really exist, because in teaching hospitals where there are more places like that, you immediately drop down on the totem pole of interested in pouring into. So back at Children's, they developed a program that was part of the fellowship was people could do an ultrasound track. And we were like, oh, this is amazing. We're going to learn ultrasound. They invested zero time in us, because they had fellows and then residents and then more residents. And so it was a very interesting experience where we would get all these residents, and even talking with our leadership, I was like, you're investing all this time and resource into people who have no interest in ER medicine. These are, neuro residents, they're family practice docs, they're peds residents who don't really even want to be here. And y'all are investing so much time, where like myself and my colleagues have desired to be here as a career. Like we would love to learn all this stuff. And so it was very much like kind of swimming upstream in that respect of just trying to figure out.
I know there are often times in our department where I wish that some of my more critical and complex patients would get picked up by our mid-levels. Can you please just grab this patient so that I can get orders that
and it's such a hard balance too sometimes, because I mean the experience I've had in the training I've done, like sure, like and this sounds weird, but sometimes those more complex kids are easier because you do a workup and they're getting admitted.
Yeah, exactly.
But
also you do the workup right now. Like you give me my orders right now and I can go do stuff and I don't have to wait or talk.
Which I try to keep an eye out for those most of the time, but there are some that are like, ooh, I don't want to step on toes. And the other thing that's interesting with the institution that we work in currently is there's less uniformability on, I don't know if that's a word, but it's less uniform on how patients are worked up. There's a little bit more flex where I came from before, there was like protocols for everything, which that became boring in a sense because I was like, man, a robot could do my job. This is what we are going to do for this. And then you let AI take over. And so it felt like you were almost the go behind. So we are totally off topic of what you guys asked me to.
And it's Kelly's fault because she said that I was allowed one question. And then you asked questions that had nothing to do with our topic. And now we're 20 minutes in. So
but no, I mean, it's super interesting to when you look at those different roles. And some of it comes through like the lens of, am I going to be backed up? Am I going to be helped? And the other thing also goes into like the specialty people that you talk to. I would say our current facility is less kind to mid-levels or nurse practitioners, PAs. Some people find mid-level offensive. I don't know. I'm not offended by it. It's, I don't know why, but some people are, but that's a different caveat and a different story. But they're just not helpful. They're annoyed rather than acting like it's their job to help you. So yeah, it's just kind of interesting. So that I think is something that probably discourages some of us from taking on some of those more complex ones. Like, I mean, last thing you want to do when you're trying to help somebody is get chewed out and accused of being an idiot. Like that doesn't, when you do that a couple of times, you're like, well, I'm okay seeing the runny nose for the same dollar.
I mean, the other side of that, though, is it might be less autonomy for the provider because you don't get to make decisions. But Kelly, I don't know how you would feel about this. I think it's more like where I worked at, we also had protocols for everything. So as a nurse, I knew exactly what I needed to do as soon as like I got the patch for that patient. So I knew that I needed this kind of line or 2 lines and these labs and these meds and all of this, and I could just do it. But
Yeah.
in our facility, because we have so much variability between providers, it's kind of like, oh, do I poke? Do I not poke?
Sure.
What do you want? What do you not want? Like,
Yeah.
do you want a swab? And so that makes us rely on, I think, the provider to get that stuff.
Yeah.
That
It's also hard too when it comes to that, because then you're like, do I just wait for instructions and risk like getting asked, why did I do none of these things? Or do
yes.
I do it and then get chewed out for not thinking it was necessary? And
Is it a
that,
sepsis alert? Is it not a sepsis
right,
alert?
right.
Who?
So
Right,
much
right.
waffle, right? It's like
Yeah. But yes, we are.
way far left of
But
wherever you were going.
what I mean, it's what I like in that all this demonstrated is that you really have like so much experience in I don't know, in like modern medicine, a lot of career experience, personal experience, and then so much education. I think that maybe the perception sometimes for people who think outside the box a little bit more is that maybe you don't have all of that. And that's, how would I say, that's why you believe what you believe. So I'm kind of curious in yours and your wife's background and how you came to like learn more about like natural interventions, how you frame that in your mind, or like what kind of
Sure.
vocabulary you use to talk about that, and how you fold that into a livelihood that is really based on medicine that, I mean, that sometimes I don't always agree with or believe in.
Yeah. Yeah. It's kind of interesting. So I grew up being in a household that utilized modern medicine. Like I got my
Mhm.
tonsils out. I had appendicitis that got fixed through surgery, and stuff like that. But at the same time, for everyday things, I don't remember going to the doctors. We would do a lot of homeopathic remedies that my mom would do. There's many stories of friends who were like, why are you breathing water under that towel over the stove? And so we would do that with essential oils when we had upper respiratory stuff, and was often called the dirty hippie because I smelled like essential oils when I would go to swim practice. They're like, oh, why do you always smell like a hippie? I'm like, I don't know. Like my mom tells me to do this stuff. But what I found with it was like when I was sick, I got better faster and didn't use antibiotics for a lot of those things. I think always had a little bit of a bent that way. But the interesting thing is the medical model that we are all trained in, and this is probably the best way that I can explain it, is we are trained with a certain toolbox. And if your problem is not solved by my toolbox, I don't know what to do with you, and there must be nothing wrong. You're fine.
Oh, okay.
Which is not necessarily true. I mean, one of the reasons so it's kind of twofold how I got into functional medicine or alternative medicine was my daughter had a tethered cord that she saw a neurosurgeon, got repaired, got released because we were told that she, could be fine, or she may have weird incontinence that starts when she's like 8, or have chronic back pain for life. And I was like, well, none of those sound great. So yes, I would like you to do the, as you're saying, the simple spine surgery that can hopefully prevent those. So she did that, and then she had some resistance to potty training, so ended up with a bunch of UTIs, and then after those things, she would just sit there and hold her stomach. And we're like, are you okay? She's like, my stomach hurts. And so just had this like kind of low level chronic abdominal pain afterwards that I was like, this is just, something's not right. And so for some of it was my own interest. And then 2, also, I think after, what would that be, like 6-7 years sitting in the ER and having all these abdominal pain come in, and get worked up by GI, you're normal. Well, the kid's having pain, like, I don't know, like, and all your tests are normal, the EGD is normal, everything's normal. We're missing something. And so started looking into functional medicine and I did all the training through the Institute of Functional Medicine, which is a hefty amount of training. But they didn't have, and they don't have, a pediatric certification at this point. And so I chose not to do the certification because I am not even able to treat with my pediatric nurse practitioner. I can't treat adults, anyone over 21. So it seemed like a waste of money for me to get certified in something that was geared towards adults. So I didn't do that, but learned a ton about the microbiome, about antibiotic use, about acid suppression, allergies, mold, like so many different things.
In that education, can I push a little bit and ask, so we don't question what is taught in medical school, right? Like we say, that's all fact. That's all what they say about the body, what they say about medical intervention, all true. I don't feel like the same believability is given to functional medicine necessarily, but which leads me to the question, do you feel like there's the same evidence-based or just inherent, do you believe the functional medicine as much as we believe the Western medicine? Like, do you believe that?
Do I personally, or does our
No, you personally, everything that you learned in functional medicine, do you think that all of what was taught is really factual and reliable?
With my original education, or
no, with the functional?
It's a bit of a hard answer because I would say it's relatively newer medicine, right? Like it's not been around for the same amount of time, but so it makes sense. And there's a lot of like physiology behind how they do it, but there's also a lot of new research that I think backs things up.
Okay.
As you continue to dig deeper.
Okay.
There's the lens in which you view it is hard though, because there's so much ingrained history of how you were taught medically and how there was like, the kooks and the crazies who, if they don't trust what we do, then they're nuts. Like,
right.
But there's a huge amount of, some of the people who are trained in functional medicine are fellowship trained gastroenterologists. They are, infectious disease doctors who have like had the same thing. Like, this is not working. What else is there? And so I think there's a growing amount of people who see two things. They see some people not getting better, or a lot of people not getting better. They see our country as a whole getting sicker, younger, and then they go like, what's going on? And so, and I think there's a lot of people who also get tired of like, I just put Band-Aids on things. Like, I want to actually help people. And so we're talking about also like two different things, like emergency medicine and what it was made for and what it does.
Okay.
Cannot be fixed by functional medicine, right? Okay. Like, it's like, I can't fix an appendicitis. If your jaw's broken, like milk and calcium aren't going to fix that, when it's like dislocated. Like, I feel like there's two different like areas, but then there's also like a blend and a cross at some point where they have to intermingle.
Well, I think you and I and Kelly probably see that, what you're talking about, these two different things, but my conversations with the crunchiest people that are in my circles that have never experienced the acute need for emergency medicine or surgical or more acute life-saving interventions don't seem to get that.
Yeah. And I think it's hard in so many ways. Until you experience it, you can't know. And if your world is framed in one way, like, you're going to doubt it until you experience it. Right. There's no way. Yeah. Because I had this as I opened my own like functional medicine pediatric practice here in Spokane.
Right.
Which was something that like, I just wanted to help people. And in the ER, seeing so many people with like chronic constipation, which again, there's structural things, and there is legit reasons why that happens. And then there's also like a complete disregard of diet, lifestyle, and just like things that could be helped without like more significant interventions. And I think there's, again, like to be able to pick and choose, like at some point there's got to be this confluence of both of these pairings so that we actually help our patients as a whole. But the two bodies are so opposed to one another that there's not a collaboration. There's like just kind of finger pointing, right? Like, you're crazy. No, you're crazy. And it's like, all right, well, how do we have both and have people get better? Like,
like many things in our culture right now, I feel like the two sides are polarized, right? So you have like your, quote unquote anti-vaxxers. And then you have like, you should get a vaccine for everything. And really like vaccine is just as, something that triggers people, which is why I'm saying it. Instead of there being like a conversation about things and, understanding that there is a place for science and there is a place for natural remedies.
Well, and it's interesting too, because a lot of the people who are opposed to these like typical medical constructs, not all of them are undereducated or just like, what we would say, like not smart people. Like some of these people are very smart who have taken the time to research on their own through medical articles and different things and come to conclusions. And I mean, take Miralax, for instance, like great drug, does the job, cleans you out. But Miralax long-term use, there's a lot of studies that are medical journals that talk about the long-term like side effects and contraindications of long-term use. For some reason, like our medical minds just like wipe that out and say like, nah, well, I can only help you now. As opposed to saying like, okay, well, like, can we use it for this specific purpose and then figure out something else? Or is there an alternative that we can accomplish the same thing? And again, so much of that is patient adherence. Like, did they actually do what was said? I mean, how many times do we get kids who come in and we tell them take Miralax and Senna for 3 days and do a clean out? And they're like, we tried that, it failed. And you're like, oh, well, how many caps did you use? 1? Well, remember we told you to use 14 in 1 day. Well, it didn't work. It didn't work. They're allergic to it. They got diarrhea. I'm like, okay, people, like
they wouldn't drink it. They wouldn't drink it.
Yeah, they wouldn't drink it.
If you ever pop to Senna, like you need to be near your house in 3 hours. Like you gotta be home.
So you also have that caveat too, right? Like even in my functional medicine practice that I had, I became disheartened because people who are seeking alternative care with quotes, they just want fast fixes also. Like they just want to pop a pill. They want it to be easy and they want it to be done. Like functional medicine is so much lifestyle medicine. I mean, it's diet and exercise. It's finding out like how your body reacts to foods, which is really challenging in a toddler. Like for in a household that has 3+ kids, they're all under 5. Kids got terrible eczema. And my recommendation is like cut out dairy and gluten for 6 months or at least 6 weeks and then see if you notice different. And not only that, but I would recommend not doing that for just you, but your whole family and see how you all feel. Oh, no way. Can't do that. And it's like, all right. Like, and then the interesting with that is as a cash pay practice, because insurance is not covered by functional medicine. Now they're mad at me for taking their money and not helping them. And I'm like,
do we start putting functional medicine in as as an option that insurance pays for? Is that what, or do we blow up insurance?
I mean, it would be great. But so the problem is that, I mean, this is getting into a lot of probably deeper conversations that you wanted, but like insurance companies control reimbursement, which controls provider application of medicine.
Yeah.
And so we're talking about a whole different story of how medicine works in general, because if the doctor actually could do what they wanted to do for a patient, insurance would just say, yes, we'll cover it. But because there's this intertwining of all of the facets that I don't fully understand, insurance mandates reimbursement. And so if they don't think something was necessary, whatever you provided either isn't covered or is not warranted, even though the medical provider who wanted to do it like prescribed it.
Is licensed.
Yeah. And so that's where, go ahead.
I heard and he's like a bodybuilder guy, but one of his things was he was being interviewed and he said, we need to deregulate big pharma. And he said, if there is a consenting adult and a licensed physician that wants to prescribe a med, even if it's not approved by the FDA, let them take it, because we'll get so much data and open up the space to smaller medicinal companies or like pharmaceutical companies. But anyway, but kind of what you're saying, like then doctors could actually prescribe drugs that they believed in, not just drugs that they got reimbursed.
It's also, I mean, I don't remember if you guys remember, do you remember the drug Aralgan? Like the Odic drop that was a pain reliever for ear aches? So when I was a nurse, that was around. And then from what I heard, the company, from our pharmacist, the company who was making it went out of business. And when it got bought by the company who purchased their company, they made some other things. The FDA decided to not reallow them to make Aralgan. Topical anesthetic for otalgia, worked amazing for those fussy kids who came in screaming with ear infections as a temporary treatment while you're treating with amoxicillin. Like, why would you not allow them to make this drug again? But then at the same time, you can find over the counter now, like topical lidocaine drops that are, potentially give you lidocaine sensitivity that, in my opinion, might be less safe. That, there's just so many things that just don't make sense in that world of the FDA. And I don't pretend to know like why they do what they do. But to your point, there's a lot of things that work that are not expensive that don't make companies money.
Mm-hmm. Yeah, I know that in my experience, I've had chronic pain issues on and off throughout my life for certain things. And I love going to see a naturopath, but he would give me like 10 vitamins that I'm supposed to be taking. Well, if I actually go and purchase all of that, it's hundreds of dollars a month.
Right.
But then my primary care will just say, oh, here, take gabapentin, which makes me feel like I'm drunk. That
and probably that costs your insurance company a decent amount of money, right?
But it doesn't cost me anything.
Right.
And my health suffers.
Right. And which one would you rather do? Be poor or feel better? I mean, that's what we're asking people to do. Flip a coin. Do you want to give away all your money, or you want to feel better? In some instances. So it's pretty interesting. I feel like you can also, you can apply that to so many different things that, alternative therapies that, even to the point of like, I can't remember what the percentage that placebo is effective. Right. Pretty high.
Cause Kelly likes to rag on me for being super weird and crunchy, but I am not.
We are a crunch light, right? Not super crunch.
Yes, that's exactly. I kind of try to remind her I'm not as bad as it gets. Like there's infinitely more crazy down the line. But what I'm interested from you and Levi, I think I'm going to run on the assumption that that we believe that these are like interventions worth doing for our family and things worth being cognizant of and spending our money on. So my question to you as an advocate for some of that functional medicine and those lifestyle changes is, as a provider, how do you handle that maybe like psychological stress of being clearly very passionately driven to help people in moments where they can't help themselves, but maybe providing care that you yourself don't believe in? And correct me if I'm inferring too much into your psyche.
I don't know if I would necessarily that I fully say like providing care I don't believe in. Okay. I think the care that we provide helps people and it works, and it's a community resource, right? Like, but I would say also that because, right, like, again, if I have you go home and put some essential oils on your gaping wound.
Right. Totally. Yeah.
So a lot of the things that we do in the ER is necessary, is life-saving, and can't be done through that functional lens that I was talking about. Right. However, how many percentage of our people come into the ER and we really, quote, as the families would say, do nothing? I did nothing for them. It's pretty high.
I'm asking more about like the constipation patient or
Okay,
the like sinus infection, like
sure.
random flu virus type thing. And they
Yeah.
come in and you're like, what I really want you to do is go home and drink some bone broth and like ride out your fever and then make some lifestyle choices. But what I'm going to do is write you a prescription for Zofran
Sure.
and Tylenol and ibuprofen because you can't buy it for whatever reason. And
Yeah.
then you're going to feed your kid Cheetos anyway. Like,
And the ER is going to give you toxic mac and cheese and goldfish.
yes. Yeah.
um,
That's
and
yeah.
so you're asking like, what do I do with that personally? Like, how do I? I, f-
Yeah.
I feel
Yeah.
like it's fairly segmented. Like I just like kind
Okay.
of put up in this box and I move it to this work
Gotcha.
category, if that makes sense. Because if people, and sometimes I will go into things a little bit deeper, like this,
Mm.
like if there's a family who's like interested, like I can tell that they're like, what else is there?
Mhm.
And I have the time, which is hard to quantify in the ER, and the ability, like I'll tell people like, hey, like, so I've done this training and like your kid's eczema is horrible. Like this is what I would start. And I also seek out a functional medicine provider to see how they can help you.
Mhm.
Like this solves, your moment. Here's your triamcinolone steroid and
Mhm.
other treatments. Like let's get you controlled. But then like when we're talking about flares and long-term stuff, like the ER is not your solution if you're wanting to like heal from this.
Okay.
And so I think it's like very much just like segmenting, like this is my ER brain, and this is what people come here for.
Mm.
And then if they have openness or questions about an alternative or functional, sometimes I'll give some resources or spend 5 to 10 minutes. But sometimes that can turn into a 30-minute conversation that I then have to figure out to actually go keep the ER running and do my job that I'm for. And so that's also the problem with functional medicine is it's slow, it's time consuming, and there's a lot of talking. And then on top of that, the thing that I found was challenging, I would say more, I don't know if emotionally or morally, was that functional medicine really is a rich person option,
Mm. Okay.
right? Like I can't provide functional medicine care to someone with Medicaid and doesn't have excessive funds to get well, right?
Mm.
When you
Mhm.
tell a family who's on food stamps to go eat organic food, like what are they like? They can't feed their family.
Yeah.
And then when you say I have that list of 10 supplements that's going to help you get better, it's probably true, but you have two barriers. You have not only convincing the family that it's going to work and will be helpful, you have to then convince them that it's worth shoving it down their autistic child's throat and having the blow up of basically withdrawal from the food they eat and the neuroexcitatory response that they get from that food.
Mhm.
You have that, potentially like 3-week window of their life being awful to get through it.
Yeah.
And then on top of that, you go to a birthday party and some super kind person makes a cake that's going to set that kid off. And then that kind person doesn't understand why that mom doesn't want them to eat their food and is offended by that. So then you have that interpersonal struggle of like, it's very
Mm.
isolating for these families when they, are, and there also is that two polarizing views of like, well, that's a crunchy, crazy mom. And,
Mhm.
when they're honestly like trying to do the best thing they can for their kid. I mean, there's so many smarter people than me who have done so much work on food. I forgot the gal's name, but it's a website called Unblind My Mind. And she's a biochemist who had an autistic child, her fifth child, who basically did a ton of research on food and found that the food that she was consuming was playing a big role in her child's like behaviors, and did like tons of work to remove it. And that kid went from being like a low functioning autistic child with an IEP to a successful, like what we would call a normotypical child, all based on mom's like diet changes and probably some supplemental stuff. Can that be everyone's story? I'm not saying that that's possible,
Right.
but the amount of work that mom took to go do that is not for the faint of heart, is not for most people who are looking for like, hey, just like, I need relief and I want
Mhm.
something to change. And so then we start talking about health as this like social construct and this like inability to actually help people
Mhm.
because one, the food available is not quality,
Right.
which I mean, you can get pretty political and if you go that bent on some of
Mhm.
those regulations and stuff, but then you have just the socioeconomical status of people not being able to afford the care that they need. And then so people just go, whatever, I'm just going to deal with it.
So, I mean, for the education and background that you have, you sound like you have a really healthy ability to provide really quality care based on what the patients are looking for, which I personally think is amazing because, as Kelly brings up often, I'm quite triggered by people's decision making in their personal life.
Yeah.
This goes to employees as well as some patients that we take care of. But I wonder, I mean, and this, Kelly, this can be my last question and then, whatever you have. So that's, how do you deal with it if you are more of this like crunch related? What would your advice be to a healthcare provider, whether it's a doctor, a mid-level or an RN, or even like some of our techs that don't prescribe to this kind of more like natural inquiry or functional medicine, when they get a family that is Western medicine hesitant?
Sure.
I'm not talking about like way out in the sticks. We only eat goat milk and what we forage, and I can't figure out why my kid's abscess is their whole foot now. Kind of like yes, those people need, like, obviously need help, but this is not the moment that we're gonna rebuild their trust in Western medicine.
Sure.
What would your advice be to people that just think that everyone that is vaccine hesitant or believes that apple cider vinegar has uses is crazy?
Um, oh man, hard thing to comment on in the sense that I think that, and this is so much of who I'm like, people don't want to be wrong, right?
Oh, I don't.
Like, right. Like
Hate it.
no one wants to be wrong. And it really feels like if you choose like something like, and hold fast to it, especially something that's like unstudied,
Mm,
unresearched, like confirmed, that you're going to be thought as dumb, ignorant, uncaring, and potentially, like in the state of Washington, I hope I can say that, potentially have CPS called on you for neglect.
mm,
Like, I mean, there's some interesting things. And so for the people who are in medicine, like looking at those people with like, that lens of like, they're
judgy.
crazy and
Yeah.
yeah, and lots of judgment, like being open to like what piece of their truth could be factual.
Mm,
Because we all grab hold of things, some more tightly than others, right? That we either, like, oh man, like, you know, I personally knew when I started doing my functional education training that I was like, I told my wife, I was like, I don't want to do this because I love what I eat and I don't want to
mm,
know what it's actually not good for me. And sure enough, I did an elimination diet, which is similar to like a Whole30 diet, except for people who do the Whole30 usually end it incorrectly. They do their 30 days and they say, praise the Lord, I can eat pizza, beer, and refined sugar all at the same time. And I'm going to do it for 24 hours. And then, man, did that feel good. But the way you're supposed to do it is to slowly reintroduce the foods you removed and see and wait and see how your body responds to things. And doing basically reintroducing those in doses and then seeing. So anyway, I removed all these foods and did this and found that I was sensitive to quite a few things, and removed them. And over the period of 2 months without trying, I lost 10 pounds and my face appearance changed from kind of being full to being not quite. I look chubby in comparison. and I wasn't even trying, but the foods that I was eating were so inflammatory that my just body was inflamed, and I had 10 pounds of inflammation that was gone because I stopped putting in my body the things. So until you experience that, you're going to 100% like say, that can't be true, you know? And so some of it is like, you have to have a willingness to like have a conversation. You have to have a willingness to like maybe do some research on what they're saying. Cause I mean, these people aren't pulling, I mean, some of them are pulling stuff from, you know, potentially unvalidated claims and different things, but then some people are finding, like I said, actual medical journals where research has been done that back up their concerns. I had one mom who brought a stack of like 15 articles on Miralax and was like, keep having problems. This is back in Colorado. And these are the articles. They say it's bad. I don't want to use it. What are my options? It's like, well, you know, mag glycinate, if you take enough of it, mag citrate can do the same thing. Like, and there's like, it's technically more natural, but like, you know, so I think it's just like for the people who are coming into those situations with medical training, remembering we've been trained one way of doing things. I mean, if we grew up in China, Chinese medicine is the go-to. It's not antibiotics or this other stuff. There's so much herbal usage. And so some of it is just our normalcy of this is what we grew up with. And so our openness to those things is challenging. But I mean, there's plenty of people practicing naturopathic medicine. There's people practicing Chinese medicine. And yet the amount of people who go there versus coming to the ER, again, it depends on, so many of those are cash pay. So if you don't have the ability to pay cash for those services, where you go?
Yeah.
Not there.
Right. The ER.
Yep. Yeah. Yeah. Even though you have suspicion and like hesitancy, like you don't have a choice in some instances.
Yeah, that's true.
I just think that's good advice, like overall for where we are in our society, of just opening up that conversation and asking questions and actually like looking at other people's point of view. I feel like we've lost that. And that's why Sam and I are like such great friends, because we do believe very different things in a lot of areas, but we are open to talking about it and making fun of each other and just, you know, having fun with it, but trying to learn something too.
Sure. I think that's kind of the problem so often is people have, and even in my own self, so much insecurity and fear of being wrong. Like, what does that do to me if I'm wrong? That we hold so tightly to our piece, almost to a fault, right? Where it's like, well, that can't be possible. Like, well, I mean, there are documented vaccine injuries. You can go look at them. Like, are they as many as people talk about? No, but do they happen? We can't say that they don't happen. And so for people to read that, even though it's maybe a low percentage, like they still have concerns about it. And so like, you know, something that happens often is we'll have families come in who demand labs, and I'm like, can't figure out why this is happening. And something I've learned to ask them is like, you know, I've tried to explain this, but you seem really worried about this. What has something happened, or is something wrong in your world that has made you? And they'll be like, oh, my friend had the exact same symptoms and their kid came in and he had cancer. Okay, now we're talking about two different things. Like me getting a CBC for that person to ensure them that they in fact don't have cancer becomes much more of an easy, empathetic thing that I can do than somebody who is just like a worry wart and has no like validity to that worry, and they're just completely distrusting of everything I do. Like two different aspects, but I can't know that unless I ask, like, can you tell me why? Like, is there something behind like why you're so worried about this? Because your kid seems otherwise pretty healthy.
I think that's an amazingly humble, and I just think that's such good perspective, Levi, to be able to go in and do that and lay it out in a nice way and be well received, and then really want to delve deeper. I would say one of my sins in the ER is I ask as few questions as I can get away with to like competently do my job sometimes, because I just don't want to be in the mess. Like, I just don't want to be in the drama of whatever is going on with that mom. Like, I just want to be part of making them better or making sure they're not going to die in the next like 48 hours.
Yeah.
And then they can deal with their psychosis at home.
Right. It's a real thing, especially for us as humans, right? Because like, for instance, last night we had a young child come in for mental health resources that was clearly behavioral. Clearly the ER is not going to do anything. Bed management, nowhere to admit them, no resources. And so we get irritated by them not knowing that.
Yeah.
And then also irritated at our system that allows that said child to potentially be abandoned in a quote safe environment. And then we, as the people who come in and want to help people and want to really make people better, are now stuck with an inconsistent environment for a child that we know does not benefit their behavior nor their outlook on life. And so we already know the outcome of what's going to happen by this person walking in the door. And we've been burnt by it. We're tired from dealing with it. And so then we build up this wall of anger and frustration of why are you even here? Instead of being able to see this person and be like, your life is really hard right now. There aren't any options for you. You moved to a different state to try to get better help and you're still not getting it. Like, wow, like, hey, that's really hard. We're going to try to help you as best we can, but just know these are the things that as a system, we're going to fail you on. And I'm really sorry about that, you know? And so that approach, I think, disarms a lot of those patients. Maybe for a minute. But and maybe for a longer amount of time. But I've had that happen a few times in that situation where those families are more willing to go home because like I actually heard what they were saying and kind of quote join their team on like, hey, yeah, this is broken. Like,
I love that. I might steal some of those questions.
Yes. I feel like those families, when you do just tell them, I get it. Like, I agree with you. There is not enough resources for your child. And I wish that I could fix that, but I personally cannot.
Yeah.
And we're angry about it too. And they do kind of understand that of like, me as your nurse in this moment, I cannot help you.
Yeah. And even interesting, if you want to talk about that specific patient in particular, like somebody who has having aggressive behaviors, who has these like quote blackout moments where they don't remember their behavior. There's a lot of practitioners and a couple that I learned from that were like legitimizing those child's feelings because of their atypical response to their neurostimuli based off of diet, trauma, like so many things that we as ER practitioners, like to our detriment, care not, don't function, can't deal with, don't know, don't have the tools to actually address that. And the other aspect to it is that's a long process. Like some of the people that I've learned from that have helped treat a child like that, it's like year plus treatment plans and a ton of commitment from the families and a ton of resources. And so much of our health is that quick fix that everyone's looking for, but like trying to figure out like, how can we support our body? How do we change what we put into our body? I mean, if you want to fix the functional medicine stuff, if you want to fix 3 things that are helpful, like food, water, and air, those are the things that you're the most exposed to, that you have the most input in. And so if there's allergens in your air environment, like, you know, looking at those types of things, food, trying to buy less processed food with fewer ingredients, and water, like get a water filter. Have you ever Googled like city tap water, the pipes? Like the fact that we drink stuff out of pipes is just crazy. Like once you start looking into this stuff and all of the potential like things. So the definition of chronic illness or autoimmunity from functional medicine is inflammation over time, basically leading to chronic illness. So, you know, if you look at the times that most people experience autoimmune diseases, it's somewhere between, 20s and mid 40s. And they're like, oh, how could this happen to me? And then you look at like, where do they live? What food have they eaten? And what has their lifestyle been like for the past 20 to 40 years? Like, it's kind of like, duh, like, of course your body would want to break and wear out and not function as appropriately. And so with a lot of stuff that I was attempting to do and to have like excitement and passion about, was trying to help those families intervene from early ages to potentially prevent disease later in life, which I think is an amazing health model. But it's so challenging because our current world system fights it, right? Like ease, comfort, ability, convenience is just fighting against that model all the time.
And the things that you said cost money. I mean, I don't have an air filter in our house and we drink city water. I think we have a filter on the house, but
I mean,
money.
the air filters, like, you're looking at $800 and a 5-year replacement filter.
Yeah.
And so people start making decisions on what they care about and what they're able to invest in. So, and it's a slow process, right, for a lot of families. And then other people just decide it's easier to take the pill, take the side effects and live with, whatever consequences they have. And again, all with the amount of ability to understand, to act on and implement the knowledge that they have access to. And some of us have better access or higher ability to interpret, and other people just do what they say.
I heard someone quoting someone, and I don't remember either of the two people, but they said, assume 100% intelligence and 0% knowledge. And I was like, I feel like that's a good, instead of walking in somewhere and assuming that someone just is dumb and doesn't understand, and that's why they're not on the same page as you or whatever, like assume that they are real, like that they have 100% intelligence and they have interpreted the world as they are, and they just might need some more information.
Yeah. Which I would say is the default of the ER person, right? Like you're dumb.
On that note, I want to be conscious of
I'll back us up for 1 sec on that, because some people come in when we talk about generational knowledge, and I've been sitting in an ER room with a great grandmother, a grandmother, a mother, and the said child, and they all look at me and they're like, they have a fever.
Oh God.
And I'm like, okay,
cool.
How long?
20
2 hours. And it was 105. And I'm like, did you give medicine? No. And I want to say, so Mom, you're telling me that your mom, grandma, who's sitting here, and your great grandma has never had a child, and you look like you've had like many based on the other people in this room. You've never seen this before? Like how? And so that idea too of like passing on information and living in a community that can help one another. So many of us are so siloed where, for many of these families, their only resource is the ER. Mm-hmm. Like they don't have anyone else to ask. They're estranged from their other family members. They're a single mom who doesn't have a dad that's in the picture, and they're just trying to get the help they need. And I think if we can step back and remember those things, and that also like people have people who die from seemingly normal things, and we just are used to seeing that stuff not, shake out as a bad thing, or the opposite. We do see it that way. I think our empathy grows for the people who we think are maybe uneducated or, dumb in those instances. So,
I mean, I think this conversation, at least for me, was really encouraging, because I think, and I've said before, Kelly, like working the ER for 8 years in adult ED, low income, low education standard, very high chronic illness, my empathy was just shot. Yeah. It was just a factory, like get in, keep you alive, send you upstairs, send you to the trauma center, send you home. Like it's hard for some of our personality types to remember some of the stuff that you're reminding us of. So I really appreciate your insight on that. And I really appreciate your, I don't want to say alternative views, because I feel like that just feeds the issue, but there's not your functional, I mean, there are things that I also adhere to in some ways, but was not raised with.
It's I think that at the end of the day, my hope for people, and these include like my colleagues that I work with that are very much like, the medical model, like, are we hurting people by doing these things? And, and if it is, we know placebo is a real thing. So if you have the mindset of like, it doesn't work, but if they think it works, it's possible it could help them. So if you just have that as a base level, and then again, you can't apply that to everything. So that can be, argued, but secondly, have you looked into it? There's a lot of resources and a lot of information that, one side or the other that people can, look into and find. And I would say we have so much trust in the medical system, and yet it fails us constantly. So I think of a simple example of that is Zantac. How many kids got prescribed Zantac over my, last 18-year career? How many? Millions.
Oh,
it was put on the black box warning for causing cancer 5 years ago. Maybe, don't quote me on that. So something that we prescribed, we trusted, we promised people it would make them better, actually didn't. So when that kind of thing happens, in my opinion, you have to go, okay, there's a possibility that what we're doing may not be the best thing.
There's other ways. Yeah. There's other ways to do things.
And once you start thinking that, I think your ability to intake information and see other people's point of view grows, and has a little bit more possibility, because there's a lot of herbalists who treat bacterial illnesses with herbs and they get better.
Yeah.
Really?
Yeah. I mean, I have a friend who has chronic sinus infections, and he was like, hey, I've been on antibiotics for 3 days. I'm not getting better. What should I do? And told him to take 4 different things. And this is his antidote. His mother-in-law had the exact same thing for the exact same amount of time. She continued the antibiotics, never got better. He took the regimen that I told him to take, and was better within 5 days. One off, maybe. I don't have a paper that I can write on it, but symptomatically, the guy got better on over-the-counter herbal supplements than somebody with strong broad spectrum antibiotics.
I drink my fire cider every shift, and I didn't get the flu.
She does. Well, Levi, I think we're going to have to stop there. We're a little over our time. But I
feel like we should probably try one thing before we stop, because you can edit all these things. So what are the most ridiculous things that crunchy people say? You got 2 of them. If you can think of one, just quotable things.
Oh, I don't put sunscreen on my child.
Oh my gosh.
wait.
Stop it right now.
Or practices.
I will be honest. When Samantha told me that she does not put sunscreen on her children because it causes skin cancer, I was just like, wow. Okay. All right. I mean, I feel bad for them, but it's your choice.
I feel bad for them because I yell at them. Don't feel bad for them because they don't have sunscreen on. Grounding. Levi, I'm gonna go with grounding.
I actually believe in grounding.
Oh man, this is hilarious.
I totally
ridiculous.
No, okay. I'm an empath, and so see, I'm a little crunchy too. But no, there is something that if I actually stand with my feet in dirt and ground myself.
You're killing me, because that's the topsoil that was brought in from God knows where when your house was built, and that grass is probably not native to where you live. It was spread wherever. So
it's about connecting with the earth.
Mother Gaia.
Oh, for goodness. Okay. Whatever. You got one, Levi?
Yeah.
No, I was just enjoying hearing the banter.
That's fine. You stand outside with your dirty feet and your sunscreen, and I'll wear my flip-flops and my big old hat. And
all right. Well, thanks for joining us, Levi.
Anytime.
Yeah. We'll see you soon.
Anytime. All right. Sounds good. Thanks, y'all.
Bye.
Oh my gosh, that was so much fun. I love talking to Levi.
He has a lot to say, for sure. About a lot of stuff, but that is perfect because that's what this podcast is about. So please, everyone that listened and enjoyed it, leave a comment. Tell us what you like about like natural medicine, holistic medicine, functional medicine, if you've ever tried it, if you've had successes, failures, what your concerns are. Maybe you are a functional practitioner yourself, and trying to help implement that more into the acute care setting as well. We are big fans of that and would love to hear your stories. So check us out on Substack, on all of the socials. We want to hear from you, and we will see you guys again next week at the nurses station. We'll save you a seat.
Bye.
Hey guys, this is Kelly from At the Nurses Station. Sam and I would like to remind you that the views and opinions expressed on this podcast are strictly our own and do not in any way reflect the position of our employers. This podcast is for entertainment purposes only and in no way should be considered medical advice. As always, consult a qualified medical provider for questions regarding your health or medical conditions. We hope you had fun listening to us today, and we'll see you next time at the Nurses Station.